For that session. I'm sure that there's probably another 350 questions waiting out there. So, and I know that you'll be available. I also want to just very quickly recognize some people that have been in the room and still in the room. From the Office of the Assembly Member Ed Chow, District Director Daisy Ma, Principal Consultant to the Assembly Health Committee Laura Flynn, from the California Senate Office of Research Principal Consultant Sandra Perez, Norlin Asbrock, Office of Assemblywoman Susan Bonilla, and Joe Parra, Policy Consultant, Senate Republican Policy. So thank you for coming. Let me go ahead and introduce our keynote speaker, Jesse Laslovich. He is the Chief Legal Counsel for the Office of Monica Lundeen in the Montana Commissioner of Securities and Insurance, who is requiring Montana's 4 largest health insurance companies to cover all prescription drugs equally beginning next year. He's been there since 2009, after serving as a Montana State Senator from Anaconda for 6 years. So with that, just a quick introduction, let me go ahead and quickly turn it over to Jesse.
Well, good morning. It's a pleasure to be here. They say that they save the best for last, and that's certainly not the case today. This is really impressive. It's an honor and a privilege for me to be here listening to Dr. Pan, Dr. Thorpe, and certainly the extraordinary panel led by Emily and with Liz and Larry and Dana and Carl, and then with Andrew. It's kind of depressing as I was listening to everybody that these folks are going to have to listen to me to conclude this great conference. It's really inspiring, and I truly mean that. It's a particular joy for me to be here as well. It's interesting hearing Dr. Pan and others talk about the rain and storms coming into Sacramento. I left our state's capital in Montana yesterday. It was 10 below zero. And so as I walked from the hotel to the convention center this morning, I felt like dancing. The rain felt really good. We have been dealing with the good and the bad and ugly of the ACA in Montana ourselves. And as I've listened to the presenters this morning, it's become clear to me that you folks here in California are way ahead of what we're doing in Montana, perhaps with the exception of the topic that I'm going to talk about. It's something to be proud of. Does it mean that it's perfect? No. Is it better than what it was prior to 2010? Absolutely. One thing that we focus on in Montana, because the conversation has been in all of in our political debates about the bad with the Affordable Care Act, that I think it's incumbent upon all of us to focus on the good. We have 1 million people in Montana. So to hear, I mean, there are more cows than people in Montana. To hear the 20 million people under the regulatory authority of the department is extraordinary to me. And I was particularly pleased to hear this morning conversation about the prohibition on pre-existing conditions. That's something that's lost. I think other items under the patient protection piece of the Affordable Care Act, we talk about the Affordable Care Act, we are dropping the patient protection out of the title, but certainly the pre-existing condition prohibition, exclusion prohibition is at the forefront, but also the bans on the annual and lifetime limits. And that truly goes to what a lot of you folks, the people that a lot of you folks represent, and certainly goes to the topic that I've been asked to talk about here this morning. Before I get into that, I want to talk a little bit about Montana. We went to the legislature in 2011 after the Affordable Care Act was signed in 2010 to try to get some of the protections in the ACA adopted into our state law so that our office could enforce them. And we were met with resounding resistance, even though our insurance carriers supported it. We tried to set up a state-based exchange. It was defeated. In 2013, we tried to do further changes consistent with the ACA thinking we're moving away from the toxicity of the 2012 election. Didn't happen. We have one hand tied behind our back in Montana because there are no ACA protections in state law. We don't have a state-based exchange. So we're stuck with, and I was interested to hear this conversation about with the panel about federal law and what our state's supposed to do. We can't do anything. We don't enforce federal law. But what we can do is when we're reviewing plans, we can say to the carriers, and we do say to the carriers, that they have to be compliant with the Affordable Care Act. Can we enforce it? No. But in our experience in Montana, we've been successful getting them in compliance with not only the ACA, but with our state law. In Montana, just 1 year, our uninsured rate went from 20% to 16.9%. That hasn't happened in the history, in the recent history of our state. We have not expanded Medicaid, which is really, really frustrating. We tried last session. The governor, the Democratic governor with the Republican legislature is going to try this session starting in January. If I'm a betting person, it's not going to pass. And that's really, really frustrating because there are thousands. You folks deal in millions of people. We deal in thousands. Thousands of people in Montana, 70,000 to be specific, who won't have any kind of access or any kind of coverage. The same goes for our rates. This is a story that I don't think is being told by us in Montana particularly. The premiums that people are paying in our market, in our individual and small group market in Montana, from 2014 to 2015, premiums went up on average 1.35%. That's kind of ridiculous to argue, right? That, whoa, they only went up a little bit when people want them to go down because they're so high in the first place. We share in that. But compared to the previous 5 years in Montana, in the individual market, it was between 13 and 18%. In the small group market, it was between 8.4 and 15.3%. That's tangible. That's money in people's pockets. Again, in 2013, you folks, I believe, have rate review in California as your insurance commissioner? No? It went down. Oh, Jennifer told me. You guys helped to feed that. So in 2013, ours is limited, but we were able to review rates, and as a result, premiums went down after review. We can't do anything. We can't approve, disapprove. We can go to the carrier and say, hey, carrier, your rates are too high, and the carrier can say, we don't care. The only thing we can do is we have the hammer of negative publicity saying that your rates are going to be excessive. So as a result of that, the carriers have reduced their premiums. So it's working well. And that leads me to why I'm here this morning in specialty tier drugs. We consider our office to be, and it's an arrogant thing to say, and I'm biased, I understand, but to be the premier consumer protection agency in the state of Montana. I used to work in the Attorney General's office and the Consumer Protection Office. They do excellent work there, but when you're talking about really affecting change, really making an impact on people, insurance it affects everybody. In Montana, we don't have a Department of Managed Health. We have the Department of Insurance. It's us. We have Department of Public Health and Human Services, but they're not regulating carriers like we are. So when we heard from the American Cancer Society, the National MS Society, that they felt that the prescription drug plans sold in Montana in 2014 were discriminatory, we took it seriously and knew that we had to do something about it. We didn't know anything about it. And you've heard about the 4 different tiers. And in Montana, for the lower tiers, as you're experiencing, it sounds like, throughout the country, there were pre-deductible copays. But for the higher tiers, and particularly the highest tier, specialty tier, it was co-insurance. So when we looked at that, our instinct was, this is discriminatory. And we heard an example in Montana of a patient whose medication cost $8,000 per month. And so with a 50% co-insurance, they had to pay $4,000 in at the beginning of the year, their planned year, at the pharmacy counter in order to receive their coverage. And this amount was just over $2,000 less than their out-of-pocket maximum. Didn't make sense. They couldn't afford it, so they wouldn't stick to their medication schedule. And I think Larry mentioned earlier, it really is kind of illogical that carriers are going to say, we're going to have co-insurance, people get off their medication schedule, and then they're going to be hospitalized, and it's going to be more expensive. And premiums are going to end up being higher. It really is very, very frustrating. So folks are either faced with, they stay on their medication, or they don't, because they simply can't afford it. That, ladies and gentlemen, is discrimination, in our opinion. So when we looked at that and we heard that, what were our options? Well, we had 4 of them. One was we could issue a bulletin, or we could do an advisory memorandum. And those of you who are familiar with state insurance department regulations, they're easy, they're simple, and it's just our office saying, here's what the law is, here's what we're going to do if you don't comply with it. We don't go through any kind of procedural junk. It's just, this is what we're going to do. Problem is, we didn't have anything in the law that would provide the legal basis for the bulletin. So and the carriers, if they push back on us, then they would win. We didn't have a legal basis. So we threw that out the window. The next one was administrative rules. Could we do administrative rules and to fix the problem? That's more cumbersome. There is a procedural process, and we felt like we didn't have a legal basis. Carriers would challenge us. They would win. The third option was legislation. Problem with the legislation piece was our legislature meets once every other year for 90 days. So they're meeting in January. It's an odd numbered years. So that meant 2015 was out the window. We were looking at 2016. We wanted to make an effect in 2015. The other piece of legislation that was troublesome to us is we didn't know what carriers would do. And if they went to the legislature and resisted our efforts, it's a fight worth having. We would have done it. But if they resisted, the legislature, I think, likely would have sided with them rather than us. Then the issue was dead. And we couldn't do anything administratively to fix it, because the carriers would simply say, you tried in the legislature, it failed, you can't do anything. So our fourth option was what we ended up going with, and that was our form review process. Similar, I presume, to Andrew's shop looking at plan designs. We have to do the same in Montana for those carriers that we regulate. Look at all the policies that they offer before they issue health plans. They can't do it without our prior approval. So when we went to that, we looked at the plans and saw, in fact, that there was a problem. Confirmed what the advocates were saying and confirmed what our initial instinct was regarding the discrimination. So what do? We need a legal basis. You can't just say, you're denied. We're not going to let you do this. You need a legal basis to say, that is the basis for your objection. And so we had 2 of them. One was discrimination. And you'll recall that we don't have any ACA provisions in Montana law. And a lot of what's complicated about this with the ACA, there's a lot of things complicated, that's stating the obvious, Jesse, right? But what's particularly complicated is insurance is state-based regulation. And you have the ACA that's federal, and if the states can't enforce their own laws because there are no ACA protections, then we're in this terrible, terrible gray area. So we stayed away from the ACA and we focused on our statute, discrimination, and the other one was unfair competition. I'll briefly talk about discrimination. That just simply means that insurers can't discriminate, which is in state law, against individuals with the same risk or hazards. This is similar throughout the country in various states. There's a variation of this state statute in every state in the country. So to hear from other insurance departments that they cannot do this, I think, to be blunt, is a cop-out. So we felt that you can't treat someone with cancer or HIV or diabetes or MS or hepatitis differently because they were in this, they had to take the specialty tier drugs than those who had similarly serious medical conditions yet were in the lower tiers. And they could, because of that, spread their costs out over the year. That inherently is discrimination. And not only discrimination, unfair, and what we said in our office, not the way we do business in Montana. And it shouldn't be that way in any state. So the second one, that one we felt really strongly about. The second legal basis, the unfair competition, I will be candid, was a little creative. Because we had one insurer in Montana who was doing the right thing, who wasn't using co-insurance, but was doing a reasonably graduated pre-deductible co-payment arrangement. So what we said in our objections to all the other carriers was, you're creating an unlevel playing field. Because once consumers find out that you're offering terrible plan designs, they're going to go to the carrier who's doing the right thing, and that's not fair to that carrier who's doing the right thing. So we think that it's unfairly competitive. You're creating it. So you need to do the right thing. I think we had more sway on the discrimination side, to be candid, but we wanted two. It's always better to have two than one. So we lodged those two objections as part of our farm review process, worked with the carriers over a period of time, and we're pleased that at the end of that process, they changed their plan designs. So there was buy-in from the carrier, and we didn't have to worry about the things, those other options I talked about, the carriers pushing back and possibly winning. We had control of it, we're their regulator. It was really a great process. So what did it do specifically? Unfortunately, we couldn't ban co-insurance, altogether because we had no law on it. But what we could, sort of that backdoor approach that Larry was talking about with the carriers, why are they doing the co-insurance? We could effectively do that by saying, okay, if you're going to offer pre-deductible co-payments in one tier, at least one tier, you're going to do it in all the tiers. It needs to be the same. And reasonably, by what I mean by same or uniform is that there has to be a co-payment rather than co-insurance. And so they did that. So it's reasonably graduated, and in Montana, in the specialty tier co-pays, they max out at $250. That's the max, and I should emphasize, that's for silver, gold, and the platinum tiers in the federally facilitated marketplace, but that's just not the marketplace in Montana. The FFM is the same as the private market. So those plans all have co-payments, specialty tier drugs, max $250, but many are much less in terms of the co-payment. It's something that we're particularly proud of. It's what's good for one is good for all. So we went as far as we could go in our negotiations, and our changes only apply in the individual market. We haven't heard any complaints in the small group market. If you have, we'd like to know about it. They don't apply in the large group, but nor do they not apply in government plans or self-funded plans or other plans that aren't within our office's regulatory authority. That's really frustrating. Small state, and we have a number of folks, I don't know if there's this movement in California that are moving to self-funded status and therefore won't have any kind of regulatory authority. That's something that I want to personally change. So while it's not perfect what we did in Montana, we think it can be a model for other state insurance departments. And in fact, I know for a fact that insurance departments throughout the country are at least interested in doing this. We've talked to them directly. They've asked us what you've done, how did you do it, and we said it's really simple. We used our state law and our form review process, and you can do it too. And some of them said, we're going to work toward that process. In fact, we've urged them to. We would urge the California, respectfully of course, the California Insurance Commissioner to do the same. I mean, and I'll just close with a few thoughts. It really makes sense to us and to our commissioner and to me. It's a no-brainer the question of whether someone who has to pay at the start of the year thousands of dollars in order to obtain their prescription versus someone who's able to pay it, spread it out over the cost of the year. It's a no-brainer where an insurance department should fall, where a consumer advocate should fall, where a consumer protection agency. We should not let carriers do this. And ultimately, the prescription drug coverage should start on January 1st. And it should not start the day after the cancer patient meets his or her deductible. It's that simple. And unfortunately, our work doesn't end here, and I really appreciated the panelists talking about some of the outreach that we need to do. We're the 4th largest state in the country. We have, the rural question resonated with me, whoever asked it. We have, towns with 10 people, and they're spread all over the place. How do you reach those people? And it's really, really frustrating in light of the toxic environment when the people who stand to benefit the most under the ACA like it the least. So we are doing our best, and our commissioner is an elected commissioner. It'll be an election in 2016, and the ACA, it speaks volumes, at least in Montana, that the ACA is still an issue that resonates with people in a negative way. I just saw this morning that the incoming United States Senate Majority Leader is saying we can't repeal Obamacare, but the United States Supreme Court can throw it out the window with the recent case that they accepted. That's so frustrating. When we said in 2011 that we want to adopt the ACA protections in Montana law, and the response was it's unconstitutional, the United States Supreme Court is going to throw it out. And we said, fine. Put a provision in there that says if the United States Supreme Court throws it out, then all this stuff goes away. We called their bluff. You think they did it? No. Of course, we know what happened. Now, the argument, I bet $1 million, this next legislative session, it's going to be the rhetoric that the incoming Senate majority just articulated this morning. That in June, when the United States Supreme Court comes out with their decision, they're going to gut the ACA. That's what we're going to deal with. And it resonates with people. And I'm getting off track, but it is so frustrating. And it's incumbent upon all of us to just say, here's what the facts are. Here's how it benefits you. Has it been perfect? No. The rollout last year was a disaster. I think Emily called it rocky. A better way of putting it. That didn't help either. But we need to tell the story. Talk about the good. In Montana, it means that we have to have health literacy outreach. We're doing that. We're training our navigators and our certified application counselors and our insurance agents to actually, with the right information so that they can inform the people that they're serving. We have our own website, Montana. It helps because we say you can call our office and actually talk to a live person rather than a dead person. I never understood talking to a live person. but that we will be available and you can talk to us. You won't be put on hold. We can do that. We have that luxury because of we don't have the people. And I'll just finish with this. We're all in this together, right?
Yes.
And I think the partnership to fight chronic disease is appropriately named. The fight, that it's not just your fight, it's our fight. And it's not just a partnership to fight chronic disease, it can be a calling, a partnership to improve the lives and the health care of not only the people of California, but the people of Montana, but the people of our country. And I'm excited about that. I'm stand ready, as does our commissioner, to help in that fight, in your fight, in our fight, as we fight to improve the lives of not only the people in our state, in your state, and all Americans. So thank you for what you all do on a daily basis. It's not unnoticed, it's incredibly appreciated and unbelievably inspiring. Thank you very much.
think that's a wonderful way to end this morning. Thanks, Jesse, for those observations. I thought the entire day was just outstanding panels. The panelists were really, really good. So I congratulate you for what you're doing here to try to make the availability of plans more transparent to patients, easier to access, and so on. I think we have a big policy agenda here to try to sort of move the paradigm ahead in terms of how we think about improving quality and controlling healthcare costs. I think the dilemma is we've been talking about health plan designs, the Olympic medal lineup of bronze and silver and so on. They really have their genesis back in the 1950s. When the issue of chronic disease was really nowhere near the issue that it is today. And those copays and deductibles were a tool to deal with moral hazard and a tool to deal with trying to keep premiums under control. We need to switch how we think about this. We are not going to control, improve quality or control the cost of treating chronically ill patients by having higher copays and higher deductibles. We're really going to do a better job of that by having more effective prevention, earlier and better disease detection, and really having patient engagement models and care coordination models that keep patients healthy. And that involves, as I mentioned before, good primary care, and it involves really having a thoughtful payment policy and a way of dealing with medications. So that's a paradigm shift. That's the controlling costs through an insurance benefit design model, fine in the 50s, not so hot in 2014, largely because the clinical makeup of patients in the system today are fundamentally different than they were 40 and 50 years ago. And we need to recognize that, I think, as a matter of public policy. So with that, I want to thank all of you for coming. I want to again thank our partners in putting this together, for the speakers who took their time to venture up to Sacramento, and keep up the good fight. You guys have a great team here, I can just tell by the energy and enthusiasm, and we'll just keep working at this and keep improving it step by step. So thanks again for coming.
I met you the other day at Red's.
Yes, yes.
Nice to see you again.
Good, thank you.